708. Section 12. Antimicrobial drugs. Cotrimazine. It is a combination of trimethoprim with sulfadiazine. Its utility is similar to that of cotrimoxazole. Trimethoprim sulfadiazine 90 mg plus 410 mg, Obril tab, 2 tab BD for 2 days, then 1 BD. 180 mg plus 820 mg, Triglobe 4 tab. Uses. Though cotrimoxazole is still used, its popularity in the treatment of systemic infections has declined. Common indications are: 1. Urinary tract infections. Most acute uncomplicated infections respond rapidly. Single-dose therapy with 4 tablets of cotrimoxazole has been used successfully for acute cystitis. Courses of 3 to 10 days have been advised for lower and upper urinary tract infections according to associated features. Cotrimoxazole is especially valuable for chronic or recurrent cases or in prostatitis because trimethoprim is concentrated in prostate. 2. Respiratory tract infections. Both upper and lower respiratory tract infections, including chronic bronchitis and fasciomaxillary infections, otitis media caused by gram-positive cocci and H. influenzae respond well. 3. Bacterial diarrheas and dysentery. Cotrimoxazole may be used for severe and invasive infections by E. coli, Shigella, non-typhoid Salmonella, and Y. enterocolitica, CP 682. Though response rate is lower than previously, and fluoroquinolones are more commonly used, it is still a valuable alternative for empirical therapy of infective diarrhea. 4. Pneumocystis jirovecii causes severe pneumonia in neutropenic and AIDS patients. Cotrimoxazole has prophylactic as well as therapeutic value, but high doses are needed. 1 DS tablet 4 to 6 times day for 2 to 3 weeks may be curative, but adverse effects necessitate discontinuation in up to 20% cases. 1 DS tab daily has been used for prophylaxis, and this is better tolerated. 5. Chancroid. Cotrimoxazole 800 plus 160 mg BD for 14 days is a third choice, but less expensive, alternative to ceftriaxone, azithromycin or ciprofloxacin. 6. Typhoid. Initially cotrimoxazole was an effective alternative to chloramphenicol. However, it has become unreliable and is seldom used now. 7. Cotrimoxazole is an alternative to penicillin for protecting agranulocytosis patients and for treating respiratory or other infections in them. Intensive parenteral cotrimoxazole therapy has been used successfully in septicemias, but other drugs are more commonly employed now. Quinolones. These are synthetic antimicrobials having a quinolone structure that are active primarily against gram-negative bacteria, though the newer fluorinated compounds also inhibit gram-positive ones. The first member nalidixic acid introduced in mid-1960s had usefulness limited to urinary and GI tract infections because of low potency, modest blood and tissue levels, restricted spectrum and high frequency of bacterial resistance. A breakthrough was achieved in the early 1980s by fluorination of the quinolone structure at position 6 and introduction of a piperazine substitution at position 7, resulting in derivatives called fluoroquinolones with high potency, expanded spectrum, slow development of resistance, better tissue penetration and good tolerability. 709. Chapter 50. Sulfonamides, cotrimoxazole and quinolones. Nalidixic acid. It is active against gram-negative bacteria, especially coliforms, E. coli, Proteus, Klebsiella, Enterobacter, Shigella but not Pseudomonas. It acts by inhibiting bacterial DNA gyrase and is bactericidal. Resistance to nalidixic acid develops rather rapidly. Nalidixic acid is absorbed orally, highly plasma protein bound and partly metabolized in liver. One of the metabolites is active. It is excreted in urine with a plasma T-8 HRS. Concentration of the free drug in plasma and most tissues attained with the usual doses is non-therapeutic for systemic infections. Mic values for most susceptible bacteria just approach the breakpoint concentration. However, high concentration attained in urine, 20 to 50 times that in plasma, and gut lumen is lethal to the common urinary pathogens and diarrhea-causing coliforms. Adverse effects. These are relatively infrequent, consist mostly of GI upset and rashes. Most important toxicity is neurological, headache, drowsiness, vertigo, visual disturbances, occasionally seizures, especially in children. Phototoxicity is rare. Individuals with G6PD deficiency may develop hemolysis. Nalidixic acid is contraindicated in infants. Dose 0.51 g TDS or QID, Gramonix 0.5 g tab, 0.3 g/5 ml susp, Diarlop 0.3 g/5 ml susp. Use 1. Nalidixic acid is primarily used as a urinary antiseptic, generally as a second-line drug in recurrent cases or on the basis of sensitivity reports. Nitrofurantoin should not be given concurrent TLY antagonism occurs. 2. It has also been employed in diarrhea caused by Proteus, E. coli, Shigella or Salmonella, but norfloxacin, cipraloxacin are more commonly used now. Fluoroquinolones. These are quinolone antimicrobials having one or more fluorine substitutions. The first-generation fluoroquinolones, FQs, introduced in 1980s have one fluoro substitution. In the 1990S compounds, with additional fluoro and other substitutions have been developed, further extending antimicrobial activity to gram-positive, cocky and anaerobes, and or conferring metabolic stability, longer T-half. These are referred to as second-generation FQs. Mechanism of action. The FQs inhibit the enzyme bacterial DNA gyrase, primarily active in gram-negative bacteria, which nicks double-stranded DNA, introduces negative supercalls, and then reseals the nicked ends. This is necessary to prevent excessive positive supercalling of the strands when they separate to permit replication or transcription. The DNA gyrase consists of 2A and 2B subunits. The A subunit carries out nicking of DNA, B subunit introduces negative supercalls, and then a subunit reseals the strands. FQs bind to a subunit with high affinity and interfere with its strand cutting and resealing function. In gram-positive bacteria, the major target of FQ action is a similar enzyme topoisomerase 4 which nicks and separates daughter DNA strands after DNA replication. Greater affinity for topoisomerase 4 may confer higher potency against gram-positive bacteria. The bactericidal action probably results from digestion of DNA by exonucleases whose production is signaled by the damaged DNA. In place of DNA gyrase or topoisomerase 4, the mammalian cells possess an enzyme topoisomerase 2 that also removes positive supercalls, which has very low affinity for FQs, hence the low toxicity to host cells. Mechanism of resistance. Because of the unique mechanism of action, plasmid-mediated transferable resistance is less likely. Resistance noted so far is due to chromosomal mutation producing a DNA gyrase or topoisomerase 4. First-generation fluoroquinolones. Norfloxacin, ofloxacin, ciprofloxacin, pefloxacin. Second generation fluoroquinolones. Levofloxacin, moxifloxacin, lomfloxacin, gemifloxacin, sparfloxacin, prolifloxacin. 710. Section 12. Antimicrobial drugs. With reduced affinity for FQs, or due to reduced permeability, increased efflux of these drugs across bacterial membranes. In contrast to nalidixic acid, which selects single-step resistant mutants at high frequency, FQ-resistant mutants are not easily selected. Therefore, resistance to FQs has been slow to develop. However, increasing resistance has been reported among Salmonella, Pseudomonas, Staphylococci, Gonococci, and Pneumococci. Ciprofloxacin prototype. It is the most potent first-generation FQ active against a broad range of bacteria. The most susceptible ones are the aerobic gram-negative bacilli, especially the Enterobacteriaceae and Neisseria. The mic of ciprofloxacin against these bacteria is usually 0.1 g/ml, while gram-positive bacteria are inhibited at relatively higher concentrations. The spectrum of action is summarized below. Highly susceptible E. coli, Neisseria gonorrhoeae K, pneumoniae N, meningitis Enterobacter H, influenzae Salmonella typhi H, Ducreae non-typhoid Salmonella Campylobacter jejuni Shigella Yersinia Enterocolitica Proteus Vibrio cholerae. Moderately susceptible Pseudomonas aeruginosa Legionella staph. Aureus brucella, including few MRSA, Listeria staph. Epidermidis bacillus anthracis Brunhamela catarrhalis mycobact. Tuberculosis. Organisms which have shown low variable susceptibility are strep, pyogenes strep, faecalis strep, pneumoniae mycoplasma, chlamydia mycobact, kansasi mycobact, avium. Notable resistant bacteria are Bacteroides fragilis, Clostridia, anaerobic cocci. The distinctive microbiological features of ciprofloxacin, also other FQs, are times bactericidal activity and high potency, MBCs are close to MICs. Times relatively long post-antibiotic effect on Enterobacteriaceae, Pseudomonas and staph. Times low frequency of mutational resistance. Times low propensity to select plasmid-type resistant mutants. Times protective intestinal streptococci and anaerobes are spared. Times active against many beta-lactam and aminoglycoside-resistant bacteria. Times less active at acidic pH. Pharmacokinetics. Ciprofloxacin is rapidly absorbed orally, but food delays absorption and first-pass metabolism occurs. The pharmacokinetic characteristics are given in Table 50.1. Ciprofloxacin and other FQs have good tissue penetrability, concentration in lung, sputum, muscle, prostate and phagocytes exceeds that in plasma, but CSF and aqueous levels are lower. It is excreted primarily in urine, both by glomerular filtration and tubular secretion. Urinary and biliary concentrations are 10 to 50-fold higher than plasma. Adverse effects. Ciprofloxacin has good safety record. Side effects occur in till 10% patients, but are generally mild. Withdrawal is needed only in 1.5%. Times gastrointestinal, nausea, vomiting, bad taste, anorexia. Because gut anaerobes are not affected, diarrhea is infrequent. Times CNS, dizziness, headache, restlessness, anxiety, insomnia, impairment of concentration and dexterity, caution while driving. Tremor and seizures are rare, occur only at high doses or when predisposing factors are present, possibly reflect GABA antagonistic action of FQs. Times skin hypersensitivity, rash, pruritus, photosensitivity, urticaria, swelling of lips, etc. Serious cutaneous reactions are rare. Times tendinitis and tendon rupture. A few cases have occurred. Risk of tendon damage is higher in patients above 60 years of age and in those receiving corticosteroids. The FQ should be stopped at the first sign of tendinitis. 711. Chapter 50. Sulfonamides, cotrimoxazole and quinolones. Table 50.1 Pharmacokinetic characteristics and doses of fluoroquinolones. Ciprofil, norfil, pefil, OFL, levofil, GEMI, prili-moxi. 1. Oral bioavailability, %. 60 to 80, 35 to 45, 90 to 185 to 95 tilde 170, 90, 85 to. Plasma protein binding, %. 20 to 35, 15, 20 to 30, 25, 25, 55 to 73, 45, 43. Wall of distribution, LKG, 3 to 4 to 1.5, 1.3 to 4. Percent metabolized 20, 25, 85, 5 to 10, 5, 90, 70 to 85. Elimination T half, HR, 3 to 5, 4 to 6, 8 to 14, 5 to 8, 8, 7, 10 to 12, 10 to 15, 6. Routes of administration oral, IV oral oral, IV oral, IV oral, IV oral oral oral, IV. 7. Dose, mg, oral 250 to 750, 400, 400, 200 to 400, 500, 3 to 0600, 400, BD, 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 OD, 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 4 100 to 200, 400 to 00500, 400. Ciprofloxacin and other FQs are contraindicated during pregnancy. On the basis of the finding that administered to immature pups ciprofloxacin and other FQs caused cartilage damage in weight-bearing joints, the FQs were contraindicated in children. However, under pressing situations like Pseudomonas pneumonia in cystic fibrosis and multiresistant typhoid, ciprofloxacin has been administered to millions of children in India and elsewhere. Though a few cases of joint pain and swelling have been reported, cartilage damage has not occurred. Caution, nevertheless, is needed while using FQs in children. Interactions. Times plasma concentration of theophylline, caffeine and warfarin is increased by ciprofloxacin, also by norfloxacin and pefloxacin. Due to inhibition of metabolism, CNS toxicity can occur by concurrent use of theophylline and AFQ. Times NSAIDs may enhance the CNS toxicity of FQs. Seizures are reported. Times antacids, sucralfate and iron salts given concurrently reduce absorption of FQs. Cifran, Ciplox, Ciprobid, Quinter, Ciprolate 250, 500, 750 mg tab, 200 mg per 100 ml IV infusion, 3 mg per milliliter eye drops. Uses ciprofloxacin is effective in a broad range of infections. Because of wide-spectrum bactericidal activity, oral efficacy and good tolerability, it is being extensively employed for empirical therapy of any infection, but should not be used for minor cases or where gram-positive organisms and or anaerobes are primarily causative. In severe infections, therapy may be initiated by IV infusion and then switched over to oral route. 1. Urinary tract infections. High cure rates, even in complicated cases or those with indwelling catheters prostatitis, have been achieved. Comparative trials have reported higher success rates than with cotrimoxazole. Chronic pseudo monas infections respond less completely. 2. Gonorrhea. Initially, a single 500 mg dose was nearly 100% curative in non-PPNG as well as PPNG infections, but cure rate has declined due to emergence of resistance, and it is no longer a first-line drug, may be used if strain is sensitive. 3. Chancroid. 500 mg BD for 3 days is a second-line alternative drug to ceftriaxone azithromycin. 4. Bacterial gastroenteritis. Currently, it is the most commonly used drug for empirical therapy of diarrhea. However, it should be reserved for severe cases due to EPC, Shigella, Salmonella and Campi. Jejuni infection. Ciprofloxacin can reduce stool volume in cholera. 5. Typhoid. Ciprofloxacin is one of the first-choice drugs in typhoid fever since chloramphenicol, ampicillin and cotrimoxazole have become unreliable due to development of resistance. In India and elsewhere up to 95% Typhi isolates were sensitive to ciprofloxacin. However, increasing number of non-responsive cases are being reported. Ceftriaxone or cefotaxime cefoperazone are more commonly. 712. Section 12. Antimicrobial drugs. Used. Ciprofloxacin given in a dose of 750 mg BD for 10 days is recommended. Patients unable to take the drug orally may be treated with 200 mg. IV 12 hourly in the beginning. Being bactericidal, the advantages of ciprofloxacin are: times quick defervescence. Fever usually subsides in 4 to 5 days but may take longer now. Times early abatement of symptoms, low incidence of complications and relapse. Times prevention of carrier state due to SIDL action, good penetration into infected cells, high biliary and intestinal mucosal concentration. It can also be used to treat typhoid carriers. 750 mg BD for 4 to 8 weeks. This has been found to achieve 92% eradication rate compared to 50% by ampicillin. For alternative drugs, see box. 6. Bone, soft tissue, gynecological and wound infections caused by resistant staph and gram-negative bacteria respond to ciprofloxacin. High cure rates have been obtained in osteomyelitis and joint infections, but prolonged treatment 6 to 8 weeks with high doses 750 mg BD is required. Used along with clindamycin metronidazole to cover anaerobes, it is a good drug for diabetic foot. 7. Respiratory infections. Ciprofloxacin should not be used as the primary drug because pneumococci and streptococci have low and variable susceptibility. However, it can treat Mycoplasma, Legionella, H. influenzae, Brand, Catarrhales and some streptococcal and pneumococcal infections besides gram-negative ones. Several second-generation FQs have now become available for the treatment of pneumonias and chronic bronchitis. The US FDA has approved use of ciprofloxacin for post-exposure treatment of inhalational anthrax which may occur due to bioterrorism. 8. Tuberculosis. It is a second-line drug which can be used as a component of combination chemotherapy against multidrug-resistant tuberculosis. Recently, even FQ-resistant TB, extensively drug-resistant or XDR-TB, have arisen. 9. Gram-negative septicemias. Parenteral ciprofloxacin may be combined with a third-generation cephalosporin or an aminoglycoside. 10. Meningitis. Though penetration in CSF is not very good, ciprofloxacin has been successfully used in gram-negative bacterial meningitis, especially that occurring in immunocompromised patients or those with CSF shunts. 11. Prophylaxis of infections in neutropenic cancer and other susceptible patients. Drugs for typhoid fever. 1. Ceftriaxone, CP 728. Currently, it is the most reliable and fastest-acting bactericidal drug for enteric fever. Practically all S-typhi isolates, including multidrug-resistant ones, are susceptible. However, it has to be injected IV, 4g daily for 2 days followed by 2g day till 2 days after fever subsides, children 75 mg/kg day, and is expensive. Generally 7 to 10 days treatment is required. Being bactericidal, it also prevents relapses and carrier state. Ceftriaxone is to be preferred over FQs in children, pregnant women and in areas with FQ resistance. Cefoperazone and cefotaxime are the other third-generation cephalosporins used in typhoid. 2. Fluoroquinolones, ciprofloxacin, 750 mg BD, is mostly used. Ofloxacin, 400 mg BD, levofloxacin, 500 mg OD BD, are nearly equally efficacious alternatives. 3. Chloramphenicol, CP 741. Since majority of S-typhi strains are now chloramphenicol resistant, it has become clinically unreliable. It is seldom used, only in case the local strain is known to be sensitive and clinical experience supports its use. It is administered orally, 0.5 g 6 hourly till fever subsides, then 0.25 g 6 hourly for another 5 to 7 days. 4. Azithromycin, 500 mg OD for 7 days, is a second-line alternative in multidrug-resistant typhoid and in patients to whom the first-line drugs cannot be given. 5. Cotrimoxazole, CP 708. It was effective in typhoid till plasmid-mediated multidrug resistance spread among S-typhi. Now it is rarely used. 6. Ampicillin amoxicillin, CP 722. These antibiotics are no longer dependable therapy for typhoid because of multidrug resistance. Response rate is low and effervescence takes longer even in patients who respond. 7. Combination therapy. There is no evidence that combination of any two or more AMAs is better than the single drug to which the infecting strain of S-typhi is responsive. 713. Chapter 50. Sulfonamides, cotrimoxazole and quinolones. 12. Conjunctivitis. By gram-negative bacteria, topical therapy is effective. Norfloxacin. It is less potent than ciprofloxacin. Mic values for most gram-negative bacteria are 2 to 4 times higher. Many pseudomonas and gram-positive organisms are not inhibited. Moreover, it attains lower concentration in tissues which are non-therapeutic. Unchanged drug as well as metabolites are excreted in urine. Norfloxacin is primarily used for urinary and genital tract infections. Given for 8 to 12 weeks, it can treat chronic UTI. It is also good for bacterial diarrheas because high concentrations are present in the gut and anaerobic flora of the gut is not disturbed. Norfloxacin is not recommended for respiratory and other systemic infections. Norbactin, Norflox 200, 400, 800 mg tab, 3 mg per milliliter eye drops, Euroflox, Norelit 200, 400 mg tab. Basagil 400 mg tab, 100 mg per 5 ml susp. Pefloxacin. It is the methyl derivative of norfloxacin, which is more lipid-soluble, completely absorbed orally, penetrates tissues better and attains higher plasma concentrations. Passage into CSF is greater than other FQs, preferred for meningeal infections. It is highly metabolized, partly to norfloxacin which contributes to its activity. Pefloxacin has longer T-half, cumulates on repeated dosing achieving plasma concentrations twice as high as after a single dose. Because of this, it is effective in many systemic infections as well. Dose of pefloxacin needs to be reduced in liver disease, but not in renal insufficiency. It is less effective in gram-positive coccal and listeria infections. Pelox 200-400 mg tab to be taken with meals, 400 mg per 5 ml inch to be diluted in 100 to 250 ml of glucose solution but not saline because it precipitates in presence of Cl ions per T, 400 mg tab. Ofloxacin. This FQ is somewhat less active than ciprofloxacin against gram-negative bacteria, but equally or more potent against gram-positive ones and certain anaerobes. Good activity against chlamydia and mycoplasma has been noted. It is an alternative drug for nonspecific urethritis, cervicitis, and atypical pneumonia caused by Chlamydia trachomatis. It also inhibits M. tuberculosis, can be used in resistant cases of TB. High activity is exhibited against M. leprae, and it is being used in alternative multidrug therapy regimens. Ofloxacin is relatively lipid-soluble, oral bioavailability is high, and higher plasma concentrations are attained. Food does not interfere with its absorption. It is excreted largely unchanged in urine. Dose needs to be reduced in renal failure. Ofloxacin is comparable to ciprofloxacin in the therapy of systemic and mixed infections. It is suitable for chronic bronchitis and other respiratory or ENT infections. Inhibition of theophylline metabolism is less marked. Gonorrhea caused by FQ-sensitive strains has been treated with a single 200 to 400 mg dose. It is also useful in chlamydia urethritis as an alternative drug. Zanocin, Tarivid 100, 200, 400 mg tab 200 mg per 100 ml IV. Infusion, Zenflox also 50 mg per 5 ml susp. Zanocin, Oflox, Exocin 0.3% eye drops. Levofloxacin. It is the active levose isomer of ofloxacin having improved activity against strep, pneumoniae and some other gram-positive and gram-negative bacteria. Anaerobes are moderately susceptible. Oral bioavailability of levofloxacin is nearly 100%. Oral and IV doses are similar. It is mainly excreted unchanged, and a single daily dose is sufficient because of slower elimination and higher potency. Theophylline, warfarin, cyclosporin and zidovudine pharmacokinetics has been found to remain unchanged during levofloxacin treatment. The primary indication of levofloxacin is community-acquired pneumonia and exacerbations of chronic bronchitis in which up to 90% cure rate has been obtained. High cure rates have been noted in sinusitis, pyelonephritis, prostatitis and other UTI as well as skin soft tissue infections. Tavanic, Glevo 500 mg tab, 500 mg per 100 ml inch. Loxof, Glevo, Levoflox, Levoday 250, 500, 750 mg tabs, 500 mg per 100 ml inch, Glevo 0.5% eye drops. 714. Section 12. Antimicrobial drug. It has been withdrawn in USA and some other countries, but is available in India, though infrequently used. Lomf 400, Lomden, Lomede 400 mg tab. Lomibact, Lox 0.3% eye drops. Sparfloxacin, another second-generation defluorinated quinolone which has enhanced activity against gram-positive bacteria, especially strep. Pneumoniae, Staphylococcus, Enterococcus, Bacteroides fragilis, other anaerobes and mycobacteria. Its major indications include pneumonia, exacerbations of chronic bronchitis, sinusitis and other ENT infections. However, it has frequently caused phototoxic reactions. Recipients should be cautioned not to go out in the sun. Prolongation of QTC interval has been noted in 3% recipients. Fatal arrhythmias have occurred in patients taking other QT prolonging drugs concurrently. It has been discontinued in many countries including USA, but not yet in India. Dose 200 to 400 mg OD oral. Torospar 200, 400 mg tab, Sparta, Sparquin, Spardac 100, 200 mg tab, Zospar, Spark, per 0.3% eye drops. Datifloxacin. This second-generation FQ with higher affinity for bacterial topoisomerase 4 was frequently used for gram-positive coccal, mainly respiratory and ENT, infections. However, it caused QT prolongation, arrhythmias, phototoxicity, and unpredictable hypoglycemia, because of which it was discontinued in most countries and has been banned in India since March 2011. Moxifloxacin, a long-acting second-generation FQ having high activity against STR, pneumoniae, other gram-positive bacteria including beta-lactam macrolide-resistant ones and some anaerobes. It is the most potent FQ against M. tuberculosis. Bacterial topoisomerase 4 is the major target of action. Moxifloxacin is primarily used for pneumonias, bronchitis, sinusitis, otitis media, in which efficacy is comparable to beta-lactam antibiotics. However, it is not good for urinary tract infections. It is primarily metabolized in liver, should not be given to liver disease patients. Side effects are similar to other FQs. It should not be given to patients predisposed to seizures and to those receiving proarrhythmic drugs, because it can prolong QTC interval. Phototoxicity occurs rarely. Dose 400 mg OD, Moxif 400 mg tab, Staxum 400 mg tab, 400 mg per 250 ml IV infusion. Moxicip, Milflox, Vigamox 0.5% eye drops for conjunctivitis caused by gram-positive as well as negative bacteria. Gemifloxacin, another broad-spectrum FQ, active mainly against aerobic gram-positive bacteria, especially strep. Pneumoniae, H. Influenzae, Moraxella, Mycoplasma pneumoniae, Chlamydia pneumophila, Klebsiella including some multidrug-resistant strains. Some anaerobes are also inhibited. It is rapidly absorbed, undergoes limited metabolism, and is excreted in urine as well as feces, both as unchanged drug and as metabolites. Dose needs to be held if creatinine clearance is less than 40 ml per minute. Side effects are diarrhea, nausea, headache, dizziness and rise in serum aminotransferases. Skin rashes are more common. It can enhance warfarin effect and carries the risk of additive QT prolongation. Gemifloxacin is indicated in community-acquired pneumonia and for acute exacerbations of chronic bronchitis. Dose 320 mg OD for 5 to 7 days. Top gum, Gembax, Gemistar, GMI 320 mg tab. Prulifloxacin. This newer second-generation FQ is a prodrug of ulifloxacin, a broad-spectrum antibacterial active against both gram-positive as well as gram-negative bacteria, including many resistant strains. Prulifloxacin is rapidly absorbed and converted to ulifloxacin during first-pass metabolism. Ulifloxacin is then excreted primarily unchanged in urine. Prulifloxacin has shown good efficacy in acute exacerbations of chronic bronchitis as well as in uncomplicated or complicated UTI. Its side effect profile is similar to that of ciprofloxacin. Gastrointestinal and CNS disturbances, urticaria and photosensitivity are reported. It is claimed not to prolong QT interval. Photosensitivity, blood dyscrasias and renal toxicity are rare. Dose 600 mg OD, single dose in uncomplicated lower UTI up to 10 days treatment for complicated UTI and bronchitis. Alpruli, Prulifox, Prulifact 600 mg tab. 715. Chapter 50. Sulfonamides, cotrimoxazole and quinolones. Problem-directed study. 50.1 A 62-year-old lady presented with acute onset frontal headache which is worse in the morning, thick, yellowish discharge from the nose, nasal blockage and fever for the past 2 days. She has been suffering from cold and cough for the last 1 week. The forehead is tender on pressing, particularly in the middle. A plain X-ray of the face and head showed both sided frontal sinusitis. Her husband informed that 3 months back she suffered an episode of depression, for which she is receiving tab amitriptyline 75 mg once daily at bedtime, and her mental condition is stable now. The doctor decides to start empirical therapy with moxifloxacin 400 mg once daily for 10 days. He also prescribes paracetamol 500 mg 8 hourly for fever and oxymetazoline nasal drops twice daily for blocked nose. A. Is the choice of antibiotic appropriate for her? If yes, what could be the considerations for selecting moxifloxacin? If no, then give reasons and suggest the alternative antibiotics that would be appropriate. See Appendix 1 for solution. 760. Section 12. Antimicrobial drugs. It is active mainly against gram-positive organisms, both cocci and bacilli. Neisseria, H. influenzae and few other bacteria are also affected. It acts by inhibiting cell wall synthesis at a step earlier than that inhibited by penicillin. Subsequently, it increases the efflux of ions by binding to cell membrane. It is bactericidal. Bacitracin is not absorbed orally. It is not given parenterally because of high toxicity, especially to the kidney. Use is restricted to topical application for infected wounds, ulcers, eye infections, generally in combination with neomycin, polymyxin, etc. Nebasulf bacitracin to 50 U plus neomycin 5 mg plus sulfestamide 60 mg per g powder, skin oint, eye oint, in neosporin 400 UG powder, 1 U is equal to 26 G. It does not penetrate intact skin, therefore, is of little value in furunculosis, boils, carbuncles, etc. Urinary antiseptics. Some orally administered AMAs attain antibacterial concentration only in urine, with little or no systemic antibacterial effect. Like many other drugs, they are concentrated in the kidney tubules and are useful mainly in lower urinary tract infection. They have been called urinary antiseptics because this may be considered as a form of local therapy. Nitrofurantoin and methenamine are two such agents, infrequently used now. Nalidixic acid, CP709, can also be considered to be a urinary antiseptic. Nitrofurantoin. It is primarily bacteriostatic, but may be acidyl at higher concentrations and in acidic urine. Its activity is enhanced at lower pH. Many gram-negative bacteria were susceptible, but due to development of resistance, activity is now restricted largely to E. coli. Resistance to nitrofurantoin does not develop during continued therapy. No cross-resistance with any other AMA is known, though it antagonizes the bactericidal action of nalidixic acid. Susceptible bacteria enzymatically reduce nitrofurantoin to generate reactive intermediates which damage DNA. Pharmacokinetics. Nitrofurantoin is well absorbed orally, rapidly metabolized in liver and other tissues, less than half is excreted unchanged in urine, plasma T half is 30 to 60 min. Antibacterial concentrations are not attained in blood or tissues. Probenecid inhibits its tubular secretion and reduces the concentration attained in urine, may interfere with its urinary antiseptic action. Renal excretion is reduced in azotemic patients. Effective concentrations may not be reached in the urine, while toxicity increases. As such, it is contraindicated in renal failure, also during pregnancy and in neonates. Adverse effects. Commonest is gastrointestinal intolerance, nausea, epigastric pain and diarrhea. An acute reaction with chills, fever and leukopenia occurs occasionally. Peripheral neuritis and other neurological effects are reported with long-term use. Hemolytic anemia is rare, except in G6PD deficiency. Liver damage and a pulmonary reaction with fibrosis on chronic use are infrequent events. Urine of patients taking nitrofurantoin turns dark brown on exposure to air. Use. The only indication for nitrofurantoin is uncomplicated lower urinary tract infection not associated with prostatitis, but it is infrequently used now. Acute infections due to E. coli can be treated with 50 to 100 mg TDS, 5 to 7 mg kg day, given for 5 to 10 days. These doses should not be used for 2 weeks at a time. Suppressive long-term treatment has been successful with 50 mg BD or 100 mg at bedtime. This dose can also be employed for prophylaxis of urinary tract infection following catheterization or instrumentation of the lower urinary tract and in women with recurrent cystitis. Furdantin 50, 100 mg tab, Urinif 100 mg tab. Nephrogesic, nitrofurantoin 50 mg plus phenazopyridine 100 mg tab. Methenamine, hexamine. It is hexamethylene tetramine, which is inactive as such, decomposes slowly in acidic urine to release formaldehyde which inhibits all bacteria. This drug exerts no antimicrobial activity in blood and tissues, including kidney parenchyma. Acidic urine is essential for its action. Urinary pH must be kept below 5.5 by administering an organic acid which is excreted as such, e.g. mandelic acid or hippuric acid or ascorbic acid. Methenamine is administered in enteric-coated tablets to protect it from decomposing in gastric juice. Mandelic acid, given as methenamine mandalate, is excreted in urine, lowers urinary pH and promotes decomposition of methenamine. Lower urinary pH itself disfavors growth of urinary pathogens. Mandelamine, methenamine mandalate 0.5 g, 1 g tab, 1 g TDS or QID with fluid restriction, daily urine volume between 1.5 L to ensure adequate concentration of formaldehyde in urine. It is not an effective drug for acute urinary tract infections or for catheterization prophylaxis. Its use is restricted to chronic, resistant type of urinary tract infections, not involving kidney substance. Resistance to formaldehyde does not occur, but methenamine is rarely used now. Adverse effects: gastritis can occur due to release of formaldehyde in stomach. Patient compliance is poor due to this. Chemical cystitis and hematuria may develop with high doses given for long periods. CNS symptoms are produced occasionally. 761. Chapter 54. Macrolide and other antibacterial antibiotics. Urinary analgesic. Phenazopyridine. It is an orange dye which exerts analgesic action in the urinary tract and affords symptomatic relief of burning sensation, dysuria and urgency due to cystitis. It does not have antibacterial property. Side effects are nausea and epigastric pain. Dose 200 to 400 mg TDS, pyridium 200 mg tab. Treatment of urinary tract infections. The general principles of use of FAMAS for urinary tract infections, UTIs, remain the same as for any other infection. Some specific considerations are highlighted below. Most UTIs are caused by gram-negative bacteria, especially coliforms. Majority of acute infections involve a single organism. Commonest is E. coli. Chronic and recurrent infections may be mixed infections. Acute infections are largely self-limiting. High urine flow rates with frequent bladder voiding may suffice. Many single-dose antimicrobial treatments have been successfully tried, but a 3-day regimen is considered optimal for lower UTIs. Upper UTIs require more aggressive and longer treatment. In any case, treatment for more than 2 weeks is seldom warranted. Bacteriological investigations are very important to direct the choice of drug. Though treatment may not wait till report comes, urine sample must be collected for bacteriology before commencing therapy. Most AMAs attain high concentration in urine, smaller than usual doses. May be effective in lower UTIs because antibacterial action in urine is sufficient. Mucosa takes care of itself. In upper UTI, pyelonephritis, antimicrobial activity in kidney tissue is needed. Therefore, doses are similar to those for any systemic infection. The least toxic and cheaper AMA should be used, just long enough to eradicate the pathogen. It is advisable to select a drug which does not disrupt normal gut and perineal flora. If recurrences are frequent, chronic suppressive treatment with cotrimoxazole, nitrofurantoin, methenamine, cephalexin or norfloxacin may be given. The status of AMAs, other than urinary antiseptics, in urinary tract infections is summarized below. 1. Sulfonamides dependability in acute UTIs has decreased. They are not used now as single drug. May occasionally be employed for suppress, sieve and prophylactic therapy. 2. Cotrimoxazole, CP708, though response rate and use have declined, it may be employed empirically in acute UTI without bacteriological data because majority of urinary pathogens, including Chlamydia trachomatis, are covered by cotrimoxazole. Given once daily at bedtime, cotrimoxazole 480 mg is often used for prophylaxis of recurrent cystitis in women as well as in catheterized patients. It should not be used to treat UTI during pregnancy. 3. Quinolones, CP711, the first generation FQs, especially norfloxacin and ciprofloxacin, are highly effective and currently the most popular drugs because of potent action against gram-negative bacilli and low cost. Nalidixic acid is seldom employed. However, to preserve their efficacy, use should be restricted. FQs are particularly valuable in complicated cases, those. Antimicrobial regimens for acute UTI, All given orally for 3 to 5 days, asterisk. 1. Norfloxacin 400 mg 12 hourly. 2. Ciprofloxacin 250 to 500 mg 12 hourly. 3. Ofloxacin 200 to 400 mg 12 hourly. 4. Cotrimoxazole 960 mg 12 hourly. 5. Cefalexin 250 to 500 mg 6 hourly. 6. Cefpodoxime proxetil 200 mg 12 hourly. 7. Amoxicillin plus clavulanic acid 500 plus 125 mg 8 hourly. 8. Nitrofurantoin 50 mg 8 hourly or 100 mg 12 hourly times 5 to 7 days. Asterisk for upper UTI, pyelonephritis, the same drugs may be given for 2 to 3 weeks. Nitrofurantoin is not suitable for pyelonephritis. The commonly used antimicrobial regimens for empirical therapy of uncomplicated acute UTI are given in the box. 762. Section 12. Antimicrobial drugs. With prostatitis or indwelling catheters and for bacteria resistant to cotrimoxazole ampicillin. Norfloxacin given for up to 12 weeks may achieve cure in chronic UTI. The FQs should not be given to pregnant women. 4. Ampicillin amoxicillin, CP 722, frequently used in the past as first-choice drug for initial treatment of acute infections without bacteriological data, but higher failure and relapse rates have made them unreliable for empirical therapy. Many E. coli strains are now ampicillin-resistant. Amoxicillin plus clavulanic acid is more frequently employed. Parenteral coamoxiclav is often combined with gentamicin for initial treatment of acute pyelonephritis. 5. Cloxacillin use is restricted to penicillinase-producing staphylococcal infection, which is uncommon in urinary tract. 6. Piperacillin carbonicillin only in serious Pseudomonas infection in patients with indwelling catheters or chronic urinary obstruction, prostatic hypertrophy, calculi, and in hospitalized patients on the basis of in vitro sensitivity. 7. Cephalosporins use is increasing, especially in women with nosocomial Klebsiella and Proteus infections. They should normally be employed only on the basis of sensitivity report, but empirical use for community-acquired infection is also common. Some guidelines recommend them as one of the options for empirical treatment of acute lower UTI. Cefalexin given once daily is an alternative drug for prophylaxis of recurrent cystitis, especially in women likely to get pregnant. 8. Gentamicin, CP 747, very effective against most urinary pathogens including Pseudomonas. However, because of narrow margin of safety and need for parenteral administration, it is generally used only on the basis of in vitro bacteriological sensitivity testing. In acute pyelonephritis, gentamicin plus parenteral amoxicillin clavulinate may be initiated empirically before bacteriological report becomes available. The newer aminoglycosides may be needed for hospital-acquired infections. 9. Chloramphenicol, though effective in many cases, use should be restricted for fear of toxicity to pyelonephritis. In cases where the causative bacteria is sensitive only to this antibiotic. 10. Tetracyclines, they are seldom effective now because most urinary pathogens have become resistant. Though broad spectrum, they are used only on the basis of sensitivity report and in CH. trachomatis cystitis. Urinary pH in relation to use of AMAs. Certain AMAs act better in acidic urine, while others in alkaline urine, see box. However, Specific intervention to produce urine of desired reaction by administering acidifying or alkalinizing agents is seldom required except for methenamine, because most drugs used in UTI attain high concentration in urine and minor changes in urinary pH do not affect clinical outcome. In case of inadequate response or in complicated cases, measurement of urinary pH and appropriate corrective measure may help. Favorable urinary pH for antimicrobial action. Acidic alkaline pH immaterial. Nitrofurantoin cotrimoxazole chloramphenicol methenamine aminoglycosides ampicillin tetracyclines, gentamicin, etc. Cloxacillin cephalosporins fluoroquinolones. In certain urease-positive proteus, they split urea present in urine into NH3 infections. It is impossible to acidify urine. In such cases, acidification should not be attempted and drugs which act better at higher pH should be used. Urinary infection in patients with renal impairment. This is relatively difficult to treat because most AMAs attain lower urinary concentration. Methenamine mandalate, tetracyclines, except doxycycline, and certain cephalosporins are contraindicated. Nitrofurantoin, nalidixic acid, and aminoglycosides are better avoided. Every effort must be made to cure the infection because if it persists, kidneys may be further damaged. Bacteriological testing and follow-up cultures are 763 Chapter 54 Macrolide and other antibacterial antibiotics. Table 54.1 Regimens for the treatment of sexually transmitted diseases. Disease causative treatment organism. First choice alternatives 1. Gonorrhea amoxicillin 3G oral or plus probenecid cefixime 400 mg once oral or nonpenicillinous ampicillin 3.5G oral 1G oral single dose doxycycline 100 mg BD times 7 days oral or producing non-PPNG erythromycin 500 mg QID times 5 days oral or penicillinase ceftriaxone 250 mg IM or plus probenecid ciprofloxacin 250 to 500 ng oral once or producing PPNG cefuroxime 1.5 GI.M or 1 G oral single dose of loxacin 200 to 400 ng oral once azithromycin 1.0 G oral single dose 2. Syphilis early, primary, secondary benzathine pen 2.4 μIM, 1 to 3 weekly inch, or doxycycline 100 mg BD oral times 15 days, or and latent less than 1 year, proc. Pen.G 1.2 μIM times 10 days, ceftriaxone 1 GIM times 7 days, or erythromycin 500 mg QID oral times 15 days. Late, greater than 1 year, benzathine pen 2.4 μIM weekly times 4 weeks, or doxycycline or erythromycin for 30 days, or proc. Pen.G 1.2 μIM times 20 days, ceftriaxone 1 GI.M.I.V times 15 days. 3. Chlamydia trachomatis azithromycin 1 G oral single dose or erythromycin 500 mg QID oral times 7 days. Nonspecific urethritis endocervicitis doxycycline 100 mg BD oral times 7 days of loxacin 400 mg BD oral x 7 days. Lymphogranuloma azithromycin 1.0 G oral weekly times 3 weeks or erythromycin 500 mg QID oral times 3 weeks. Venereum doxycycline 100 mg BD oral times 3 weeks. Aspirate fluctuant lymph node 4. Granuloma inguinale tetracycline 500 mg QID oral times 3 weeks or erythromycin 500 mg QID oral times 3 weeks. Donovanosis doxycycline 100 mg BD oral times 3 weeks or Calin. Granulomatous azithromycin 500 mg OD oral times 7 days or 1.0 weekly oral times 4 weeks 5. Chancroid ceftriaxone 0.25 g IM single dose or ciprofloxacin 500 mg BD oral times 3 days or H. ducreyi, azithromycin 1.0 g oral single dose or doxycycline 100 mg BD oral times 7 days or erythromycin 0.5 g QID oral times 7 days cotrimoxazole 960 mg BD oral times 14 days. 6. Genital herpes simplex first episode acyclovir 200 mg 5 times a day 400 ng TDS oral times 10 days or does not prevent valacyclovir 0.5 to 1.0 g BD oral times 10 days or recurrences famciclovir 250 mg TDS oral times 5 days. Acyclovir 5% oint locally 6 times a day times 10 days may afford relief in mild cases. Recurrent episode. The above drugs are given for 3 to 5 days. Topical acyclovir is ineffective. Suppressive treatment acyclovir 400 mg BD oral times 6 to 12 months or valacyclovir 500 mg OD oral times 6 to 12 months. Or famciclovir 250 mg BD oral times 6 to 12 months 7. Trichomonas metronidazole to G single dose or 400 mg TDS times 7 days, clotrimazole 100 mg intravaginal. Vaginitis or tinidazole to G single dose or 600 mg OD times 7 days every night times 6 to 12 days. Treat the male partner also if recurrent. 764. Section 12. Antimicrobial drugs. A must to select the appropriate drug and to ensure eradication of the pathogen. Potassium salts and acidifying agents are contraindicated. Prophylaxis for urinary tract infection. This may be given when a. Women of childbearing age have recurrent cystitis. B. Catheterization or instrumentation inflicting trauma to the lining of the urinary tract is performed, bacteremia frequently occurs and injured lining is especially susceptible. C. Indwelling catheters are placed. D. Uncorrectable abnormalities of the urinary tract are present. E. Inoperable prostate enlargement or other chronic obstruction causes urinary stasis. The most frequently used drugs for prophylaxis of lower UTI are times cotrimoxazole 480 mg times nitrofurantoin 100 mg times norfloxacin 400 mg times cephalexin 250 mg all drugs are given once daily at bedtime. Treatment of sexually transmitted diseases, STDs. The effectiveness of various AMAs in treating different STDs is described with the individual drugs. The preferred drugs and regimens for important STDs are summarized in Table 54.1. Problem-directed study. 54.1 A 35-year-old woman came to the OPD with complaints of urinary urgency, pain and burning during urination, suprapubic discomfort and low-grade fluctuating fever for the past 2 days. She had 3 to 4 similar episodes over the last year, for which she took treatment from a local doctor. She is married, has 3 children, and her last menstrual period was 10 days back. She is neither using nor is willing to use a contraceptive. Physical examination reveals tenderness in the suprapubic region and body temperature 100.4 degrees Fahrenheit. A diagnosis of acute cystitis is made and she is advised to get urine culture and blood tests done. A. Should empirical antimicrobial treatment be started after urine sample has been taken for testing? If so, which drugs would be appropriate? B. Can any drug be given to rapidly relieve urinary symptoms? C. Should long-term prophylactic drug be prescribed in her case? If so, which drug would be suitable for her? See Appendix 1 for solution. Chapter 57 Antifungal Drugs. These are drugs used for superficial and deep, systemic, fungal infections. A disquieting trend after 1950s is the rising prevalence of more sinister type of fungal infections which are, to a large extent, iatrogenic. Fungal infections are mostly associated with the use of broad-spectrum antibiotics, corticosteroids, anti-cancer immunosuppressant drugs, dentures, indwelling catheters and implants, and emergence of AIDS. As a result of breakdown of host defense mechanisms by the above agents, saprophytic fungi easily invade living tissue. Many topical antifungals have been available since the antiseptic era. Two important antibiotics with amphotericin B to deal with systemic mycosis and griseofulvin to supplement attack on dermatophytes were introduced around 1960. Antifungal property of flucytosine was noted in 1970, but it could serve only as a companion drug to amphotericin. The development of imidazoles in the mid-1970s and triazoles in 1980s has been an advancement. Terbinafine is a novel antifungal, a group of potent semisynthetic antifungal antibiotics. The echinocandins are the latest addition. Classification 1. Antibiotics A. Polines, amphotericin B, AMB, nystatin, hemicin B, echinocandins, caspofungin, micafungin, anidulafungin C, heterocyclic benzofuran, griseofulvin 2. Antimetabolite fucytosine, 5-FC, 3. Azoles A. Imidazoles topical, clotrimazole, econazole, miconazole, oxyconazole systemic, ketoconazole. B. Triazoles, fluconazole, systemic, itraconazole, voriconazole, posaconazole 4. Allylamine terbinafine 5. Other topical agents tolnaftate, undecylenic acid, benzoic acid, quinidoclor, cyclopyroxolamine, butenafine, sod. Thiosulfate. Polyene antibiotics. The name polyene is derived from their highly double-bonded structure. Amphotericin B is described as the prototype. Amphotericin B, AMB. It is obtained from Streptomyces nodosus. Chemistry and mechanism of action. The polyenes poses a macrocyclic ring, one side of which has several conjugated double bonds and is highly lipophilic, while the other side is hydrophilic with many O groups. A polar amino sugar and a carboxylic acid group are present at one end in some. They are all insoluble in water and unstable in aqueous medium. The polyenes have high affinity for ergosterol present in fungal cell membrane. They combine with it, get inserted into the membrane, and several polyene molecules together orient themselves in such a way as to form a micropore. The hydrophilic side forms the interior of the pore through which ions, amino acids, and other water-soluble substances move out. The micropore is stabilized by membrane sterols, which fill up the spaces between the AMB molecules on the lipophilic side, constituting the outer surface of the pore. Thus, cell permeability is markedly increased. 788. Section 12. Antimicrobial drugs. Cholesterol, present in host cell membranes, closely resembles ergosterol. The polyenes bind to it as well, though with lesser affinity. Thus, the selectivity of action of polyenes is low, and AMB is one of the most toxic systemically used antibiotics, though it is the least toxic pollen. Bacteria do not have sterols and are unaffected by pollens. It has been found that AMB enhances immunity in animals, and this action may aid immunocompromised individuals in handling fungal infection. Antifungal spectrum AMB is active against a wide range of yeasts and fungi. Candida albicans, Histoplasma capsulatum, Cryptococcus neoformans, Blastomyces dermatitidis, Coccidioides immitis, Torulopsis, Rhodotorula, Aspergillus, Sporothrix, etc. Dermatophytes are inhibited in vitro, but concentrations of AMB attained in infected skin are low and ineffective. It is fungicidal at high and static at low concentrations. Resistance to AMB during therapy has been rarely noted among Candida in a selected group of leukopenic cancer patients, but it is not a problem in the clinical use of the drug. AMB is also active on various species of Leishmania, a protozoa. Pharmacokinetics AMB is not absorbed orally. It can be given orally for intestinal candidiasis without systemic toxicity. Administered IV as a suspension made with the help of deoxycholate, DOC, it gets widely distributed in the body, but penetration in CSF is poor. It binds to sterols in tissues and to lipoproteins in plasma and stays in the body for long periods. The terminal elimination T-half is 15 days. About 60% of AMB is metabolized in the liver. Excretion occurs slowly both in urine and bile, but urinary concentration of active drug is low. Administration and dose amphotericin B can be administered orally, 50 to 100 mg QID, for intestinal moniliasis, also topically for vaginitis, otomycosis, etc., Fungizone otic 3% ear drops. Conventional formulation of AMB, CAMB, for systemic mycosis, CAMB is available as dry powder along with deoxycholate, DOC, for extemporaneous dispersion before use, Fungizone intravenous, Mycol 50 mg vial. It is first suspended in 10 ml water and then diluted to 500 ml with glucose solution. Saline makes the suspension course, should be avoided. Initially 1 mg test dose is injected IV over 20 minutes. If no serious reaction follows, 0.3 mg per kilogram is infused over 4 to 8 hours. Daily dose may be gradually increased to 0.7 mg/kg depending on tolerance of the patient. The total dose of AMB for majority of cases is 3 to 4 g given over 2 to 3 months. Intrathecal injection of 0.5 mg twice weekly has been given in fungal meningitis. Liposomal amphotericin B, LAMB, it has been produced to improve tolerability of IV infusion of AMB, reduce its toxicity and achieve targeted delivery. It consists of 10% AMB incorporated in uniform-sized 60 to 80 nm unilaminar liposomes made up of lecithin and other biodegradable phospholipids. The special features of this preparation are times it produce milder acute reaction on IV infusion. Times it can be used in patients not tolerating infusion of conventional AMB formulation. Times it has lower nephrotoxicity. Times it causes minimal anemia. Times it delivers AMB particularly to reticuloendothelial cells in liver and spleen, especially valuable for Kala Azar and in immunocompromised patients. The liposomal AMB produces equivalent blood levels, has similar clinical efficacy with less acute reaction and renal toxicity than conventional preparatin. It thus appears more satisfactory, can be infused at higher rates, 3 to 5 mg/kg day, but is many times costlier than conventional AMB. LAMB is specifically indicated for empirical therapy in febrile neutropenic patients not responding to antibacterial antibiotics, critically ill deep mycosis cases, and in Kala Azar. Fungism, liposomal AMB, 10 mg, 25 mg, 50 mg per vial. Inj Amfolip 10 mg per 2 ml, 50 mg per 10 ml, 100 mg per 20 ml Inj. Another formulation amphotericin B colloidal dispersion, ABCD, containing 50% each of AMB and cholesterol sulfate has been produced, but is not superior. Adverse effects. The toxicity of AMB is high. A. Acute reaction. This occurs with each infusion and consists of chills, fever, aches and pain all over, nausea, vomiting and dyspnea lasting for 2 to 5 hours, probably due to release of cytokines, TNF. When the reaction is severe, the dose should be increased gradually. Usually the intensity of reaction decreases with continued medication. Injection of hydrocortisone 0.6 mg/kg with the infusion may reduce the intensity of reaction. Thrombophlebitis of the injected vein can occur. 789. Chapter 57. Antifungal drugs. B. Long-term toxicity. Nephrotoxicity is the most important. It occurs fairly uniformly and is dose-related. Manifestations are azotemia, reduced GFR, acidosis, hypokalemia and inability to concentrate urine. It reverses slowly and often incompletely after stoppage of therapy. Anemia. Most patients develop slowly progress ING anemia, which is due to bone marrow depression. It is largely reversible. CNS toxicity occurs only on intrathecal injection, headache, vomiting, nerve palsies, etc. Uses. Amphotericin B can be applied topically for oral, vaginal and cutaneous candidiasis and otomycosis. It is the most effective drug for various types of systemic mycosis and is the gold standard of antifungal therapy. However, because of higher toxicity of AMB, the azole antifungals are now preferred in conditions where their efficacy approaches that of AMB. See Table 57-1. Febrile neutropenia. Empirical use of IV AMB is often made in neutropenic patients whose fever is not responding to IV bactericidal antibiotics. Leishmaniasis. AMB is the most effective drug for resistant cases of Kala Azar and mucocutaneous leishmaniasis, CCH60. Interactions. Flucytosine has supraadditive action with AMB in the case of fungi sensitive to both. AMB increases the penetration of 5-FC into the fungus. Aminoglycosides, vancomycin, cyclosporin and other nephrotoxic drugs enhance the renal impairment caused by AMB. Nystatin. Obtained from S. norsae, it is similar to AMB in antifungal action and other properties. However, because of higher systemic toxicity, it is used only locally in superficial candidiasis. Mycostatin 5 lakh U tab, 1 lakh U vaginal tab, 1 lakh UG oint, Nystin I 1 lakh UG ophthalmic oint. Given orally, it is not absorbed, can be used for monilial diarrhea due to superinfection or otherwise. 5 lakh U TDS, 1 mg is equal to 2000 U. Nausea and bad taste in mouth are the only side effects. Table 57.1 Choice of drugs for systemic mycosis. Disease drugs. First choice, second choice. 1. Candidiasis oral vaginal cutaneous flu envious clo itr deep invasive AMB vori flu cas posa 2. Cryptococcosis AMB plus or minus 5 FC flu 3. Histoplasmosis ITR AMB flu 4. Coccidioidomycosis AMB flu ITR KTZ 5. Blastomycosis ITR AMB KTZ flu 6. Sporotrichosis, disseminated, AMB ITR 7. Paracoccidioidomycosis ITR AMB 8. Aspergillosis vori AMB ITR Cas POSA 9. Mucormycosis AMB POSA 10. Chromomycosis ITR TER POSA. AMB amphotericin B, 5, FC, flucytosine, KTZ, ketoconazole, fluconazole, ITR, itraconazole, NVIS, nystatin, clotrimazole, voriconazole, caspofungin, posaconazole, TER, terbinafine. 790. Section 12. Antimicrobial drugs. Nystatin is effective, but less than azoles. In monilial vaginitis, 1 lakh U tab inserted twice daily. For oral thrush, the vaginal tab may be crushed and suspended in glycerin for application in mouth. Corticosteroid aerosols, e.g. beclomethasone, can cause oral candidiasis. Nystatin is effective in preventing as well as treating it. Similarly, it is used for corneal, conjunctival and cutaneous candidiasis in the form of an ointment. No irritation or other side effect is ordinarily seen. Candidal resistance to nystatin is not a clinical problem. It is ineffective in dermatophytosis. Hemicin. It was isolated from S. pimprina and developed by Hindustan Antibiotics at Pimpri. It is similar to nystatin but more water-soluble. A fraction of the orally administered dose is absorbed but cannot be relied upon for the treatment of systemic mycosis. Use is restricted to topical application for oral thrush, cutaneous candidiasis, monilial and trichomonas vaginitis and otomycosis by aspergillus. Hemicin, 5 lakh UG oint, 2 lakh U ml susp for topical use, 4 lakh U vaginal ovules. Echinocandins. These are a new class of potent semisynthetic antifungal antibiotics with a complex cyclic lipopeptide structure, which stand out due to their low toxicity compared to AMB. Caspofungin. It is the first and the prototype member of the class, active mainly against Candida and Aspergillus. Strains of Candida that have become resistant to azoles are susceptible to caspofungin. The mechanism of action is different from other antifungals, which it inhibits the synthesis of beta-1, 3-glucan, which is a unique component of the fungal cell wall. Cross-linking between chitin, a fibrillar polysaccharide, and beta-1, 3-glucan gives toughness to the fungal cell wall. Weakening of the cell wall by caspofungin leads to osmotic susceptibility of fungal cell, which then succumbs. Caspofungin is not absorbed orally, has to be infused IV. It is distributed into tissues, but does not enter CSF. Metabolism is extensive and metabolites are excreted in urine as well as feces with a plasma T half of 10 hours. Caspofungin is approved for use in deep and invasive candidiasis, esophageal candidiasis and salvage therapy of non-responsive invasive aspergillosis. Because of good tolerability, it is now increasingly used in neutropenic immunocompromised patients whose fever is not responding to antibacterial antibiotics. Dose: 70 mg loading dose infused IV over 1 hour, followed by 50 mg IV daily. Cansidas 70 mg in 10 ml and 50 mg in 10 ml each. An acute febrile reaction sometimes attends the IV infusion of caspofungin, as does phlebitis of the injected vein. Rash, vomiting, dyspnea, hypokalemia and joint pain may occur. However, organ toxicity has not been noted. Micafungin and anidulafungin are the other echinocandins with similar properties. Heterocyclic benzofuran. Grizofulvin. It was one of the early antibiotics extracted from Penicillium grisofulvum. However, because of lack of antibacterial activity, little attention was paid to it. Clinical utility in dermatophytosis was demonstrated only around 1960. Grizofulvin is fungistatic for most dermatophytes, including epidermophyton, trichophytone, microsporum, etc., but not against Candida and other fungi causing deep mycosis. Bacteria are also insensitive. Dermatophytes actively concentrate it. This feature probably accounts for its selective toxicity. Resistance can be induced in vitro, and this is associated with loss of concentrating ability. However, emergence of resistance during clinical use is rare. Grizofulvin interferes with mitosis. Multinucleated and stunted fungal hyphae are produced under its action. It also causes abnormal metaphase configurations. However, unlike the typical mitotic inhibitors, colchicine, Vinca alkaloids, it does not cause metaphase arrest, rather the daughter nuclei fail to move apart or move only a short distance. It does not inhibit polymerization of tubulin, microtubular protein which pulls the chromosomes apart, but binds to polymerized microtubules and interferes with their function. 791. Chapter 57. Antifungal drugs. Pharmacokinetics. The absorption of grizofulvin from GIT is somewhat irregular because of its very low water solubility. Absorption is improved by taking it with fats and by microfining the drug particles. Now ultramicrofine particle preparations from which absorption is still better are available. Grizofulvin gets deposited in keratin-forming cells of skin, hair and nails. It is especially concentrated and retained in tinea-infected cells. Grizofulvin is largely metabolized, primarily by methylation and excreted in urine. Plasma T-half is 24 hours, but it persists for weeks in skin and keratin. Adverse effects. Toxicity of grizofulvin is low and usually not serious. Headache is the commonest complaint, followed by GIT disturbances. CNS symptoms and peripheral neuritis are occasional. Rashes, photoallergy may warrant discontinuation. Gynecomastia is reported. Transient leukopenia and albuminuria, without renal damage, are infrequent. Use. Grizofulvin is used orally only for dermatophytosis. On getting deposited in the skin through circulation, it prevents fungal invasion of keratin. Because it is fungistatic and not cidal, the newly formed keratin is not invaded by the fungus, but the fungus persists in already infected keratin till it is shed off. Thus, the duration of treatment is dependent upon the site of infection, thickness of infected keratin and its turnover rate. It is ineffective topically. Systemic azoles and terbinafine are equally or more efficacious and are preferred now. Dose 125 to 250 mg QID with meals. Duration depends on the site of infection, turnover rate of keratin. Scalp 4 weeks. Palm, soles 6 to 8 weeks. Fingernails 6 to 8 months. Toenails 10 to 12 months. Majority of localized tinea infections are treated with topical agents. Grizofulvin should be reserved for cases with nail or large body surface involvement and tinea capitis. It is effective in athlete's foot but not in pityriasis versicolor. Grisovin FP, Valavin, Grizoryl 250 mg tab. Interactions. Grizofulvin induces CYP450 enzymes and hastens warfarin metabolism. Efficacy of oral contraceptives may be lost. Phenobarbital reduces the oral absorption and induces the metabolism of grizofulvin. Failure of therapy may occur. Grizofulvin can cause intolerance to alcohol. Antimetabolite. Flucytosine, 5-FC. It is a pyrimidine antimetabolite which is inactive as such. After uptake into fungal cells, it is converted into 5-fluorouracil and then to 5-fluorodeoxyuridylic acid, which is an inhibitor of thymidylate synthesis. Thymidyllic acid is a component of DNA. The fungal selectivity of 5-FC depends on the fact that mammalian cells, except some marrow cells, have low capacity to convert 5-FC into 5-fluorouracil, which is a potent anticancer drug. 5-FC is a narrow-spectrum fungistatic, active against Cryptococcus neoformans, Torula, Chromoblastomyces, and a few strains of Candida. Other fungi and bacteria are insensitive. Adverse effects. Toxicity of 5-FC is lower than that of AMB, consists of dose-dependent bone marrow depression and gastrointestinal disturbances, particularly enteritis and diarrhea. Liver dysfunction is mild and reversible. Use. Flucytosine is not employed as the sole therapy except occasionally in chromoblastomycosis. Rapid development of resistance limits its utility in deep mycosis. In cryptococcosis, both meningeal and non-meningeal, its synergistic action with AMB is utilized to reduce the total dose of the more toxic latter drug. Therapy with 5-FC is generally limited to first 2 weeks of AMB regimen to avoid its bone marrow toxicity. Imidazoles and triazoles. These are presently the most extensively used antifungal drugs. 4 imidazoles are entirely topical, while ketoconazole is used both orally and topically. 2 triazoles, fluconazole and itraconazole, have largely replaced ketoconazole for systemic mycosis because of greater efficacy, longer T-half, as well as fewer side effects. Some newer triazoles have been added. The imidazoles and triazoles have broad-spectrum antifungal activity covering dermatophytes, Candida, other fungi involved in deep mycosis, except mucor, nocardia and leishmania. The mechanism of action of imidazoles and triazoles is the same. They inhibit the fungal cytochrome P450 enzyme lanosterol 14 demethylase and thus impair ergosterol synthesis, leading to a cascade of membrane abnormalities in the fungus. The lower host toxicity of triazoles compared to imidazoles has correlated with their lower affinity for mammalian CYP450 enzymes and lesser propensity to inhibit mammalian sterol synthesis. 792. Section 12. Antimicrobial drugs. Development of fungal resistance to azoles has been noted among Candida infecting advanced AIDS patients, but has not so far posed significant clinical problem in immunocompetent patients, except fluconazole resistance among Candida causing esophageal and other deep candidiasis. Many of fluconazole-resistant Candida respond to itraconazole or to voriconazole. Mutation of the gene encoding for fungal 14-demethylase enzyme underlies azole resistance. Clotrimazole. It is effective in the topical treatment of tinea infections like ringworm. 60-100% cure rates are reported with 2 to 4 weeks application on a twice-daily schedule. Athlete's foot, otomycosis, and oral cutaneous vaginal candidiasis have responded in greater than 80% cases. It is particularly favored for vaginitis because of a long-lasting residual effect after once daily application. A 7-day course is generally used. For oropharyngeal candidiasis, 10 mg troche of clotrimazole is allowed to dissolve in the mouth 3 to 4 times a day, or the lotion gel is applied swirled in the mouth for as long as possible. It is also effective in skin infections caused by corynebacteria, but like most topical antifungals, has poor efficacy in tinea capitis, scalp, and tinea unguium, nails. Clotrimazole is well tolerated by most patients. Local irritation with stinging and burning sensation occurs in some. No systemic toxicity is seen after topical use. Surface Cloderm 1% lotion, cream, powder, 100 mg vaginal. Tab Candid 1% cream, mouth paint, powder. Econazole. It is similar to clotrimazole, penetrates superficial layers of the skin and is highly effective in dermatophytosis, otomycosis, oral thrush, but is somewhat inferior to clotrimazole in vaginitis. No adverse effects, except local irritation in few is reported. Econazole 1% oint, 150 mg vaginal tab, Ecoderm 1% cream. Miconazole. It is a highly efficacious, greater than 90% cure rate, drug for tinea, pityriasis versicolor, otomycosis, cutaneous and vulvovaginal candidiasis. Because of its good penetrating power, it has been found effective, though partially, even in onychomycosis. Single application on skin acts for a few days. Irritation after cutaneous application is infrequent. No systemic adverse effects are seen. However, a higher incidence of vaginal irritation is reported in comparison to clotrimazole. Even pelvic cramps have been experienced. Dactarine 2% gel, 2% powder and solution, gynodactarine 2% vaginal gel, Zole 2% oint, lotion, dusting powder and spray, 1% ear drops, 100 mg vaginal ovules. Oxyconazole. Another newer topical imidazole antifungal effective in tinea and other dermatophytic infection, as well as vaginal candidiasis. Local irritation can occur in some patients. Oxygen, Zoderm, oxyconazole 1% with benzoic acid 0.25% cream lotion, apply topically once or twice daily. Ketoconazole, KTZ. It is the first orally effective broad-spectrum antifungal drug, useful in both dermatophytosis and deep mycosis. The oral absorption of KTZ is facilitated by gastric acidity because it is more soluble at lower pH. Hepatic metabolism is extensive. Metabolites are excreted in urine and feces. Elimination of KTZ is dose-dependent. T-half varies from 1.5 to 6 hours. Penetration in CSF is poor, therefore not effective in fungal meningitis. However, therapeutic concentrations are attained in the skin and vaginal fluid. In spite of relatively short T-half, a single daily dose is satisfactory in less severe cases. The usual dose is 200 mg OD or BD. Fungicide, Nizral, Funazole, Ketoweight 200 mg tab. Funginoc 2% oint, 2% shampoo, for dandruff, Ketoweight 2% cream. Nizral 2% cream, 2% lotion, Dandruff 2% shampoo, Hyforal 2% lotion. Adverse effects. Ketoconazole is much less toxic than AMB, but more side effects occur than with itraconazole or fluconazole, that have largely replaced it for systemic use. The most common side effects are nausea and vomiting, can be reduced by giving the drug with meals. Others are loss of appetite, headache, paresthesia, rashes and hair loss. The most important drawback of KTZ is its hormonal effects. It decreases androgen production from testes and displaces testosterone from protein binding sites. 793. Chapter 57. Antifungal drugs. Gynecomastia, loss of hair and libido, and oligospermia may occur when the drug is used for a few weeks. Menstrual irregularities occur in some women due to suppression of estradiol synthesis. A dose-dependent decrease in serum hydrocortisone due to synthesis inhibition has also been noted, but without any clinical manifestations in normal individuals. Mild and asymptomatic elevation of serum transaminases occurs in till 5% patients, but serious hepatotoxicity is infrequent. It is contraindicated in pregnant and nursing women. Interactions: ketoconazole and most azoles interact with several drugs. Due consideration must be given when they are co-prescribed with other drugs. H2 blockers, proton pump inhibitors, and antacids decrease oral absorption of KTZ by reducing gastric acidity. Rifampin, phenobarbital, carbamazepine, and phenytoin induce KTZ metabolism and reduce its efficacy. Ketoconazole inhibits CYP450 enzymes, especially CYP3A4, CYP2C9, CYP2C19, and raises the blood levels of several drugs including phenytoin digoxin, carbamazepine, omeprazole, diazepam, cyclosporin, haloperidol, nifedipine, and other DHPs, warfarin, HIV protease inhibitors, sulfonylureas, statins. The dangerous interaction with terfenadine, astamizole, and cisapride resulting in polymorphic ventricular tachycardia due to excessive rise in plasma levels of these drugs has resulted in their withdrawal. CP 166. Use: orally administered KTZ is effective in dermatophytosis because it is concentrated in the stratum corneum. It is an alternative to griseofulvine, but use is restricted due to potential adverse effects. Used as a lotion or shampoo, KTZ is quite effective in seborrhea of scalp and dandruff. Though effective in monilial vaginitis, oral therapy for 5 to 7 days with KTZ is reserved for recurrent cases or those not responding to topical agents. Systemic mycosis, administered orally. KTZ is effective in several types of systemic mycosis, but triazoles, being more active with fewer side effects, have largely replaced it for these indications. KTZ is occasionally used in dermal leishmaniasis and in Kala-Azar. High-dose KTZ has been used in Cushing's syndrome to decrease corticosteroid production. Fluconazole: it is a water-soluble triazole having a wider range of activity than KTZ. Indications include cryptococcal meningitis, systemic and mucosal candidiasis in both normal and immunocompromised patients, coccidioidal meningitis, and some tinea infections. Fluconazole is 94% absorbed. Oral bioavailability is not affected by food or gastric pH. It is primarily excreted unchanged in urine with AT half of 25 to 30 HR. Fungicidal concentrations are achieved in nails, vagina and saliva. Penetration into brain and CSF is good. Dose reduction is needed in renal impairment. Adverse effects: fluconazole produces fewer side effects, mostly nausea, vomiting, abdominal pain, rash, and headache. Incidence and severity of these side effects increases with dose and duration of therapy. Selectivity for fungal cytochrome P450 is higher. Unlike KTZ, it does not inhibit steroid synthesis in man. Antiandrogenic and other endocrine side effects have not occurred. Elevation of hepatic transaminase has been noted in AIDS patients. It is not recommended in pregnant and lactating mothers. Interactions: though it affects hepatic drug metabolism to a lesser extent than KTZ, increased plasma levels of phenytoin, astamizole, cisapride, cyclosporin, warfarin, zidovudine, and sulfonylureas have been observed. A few cases of ventricular tachycardia have been reported when fluconazole was given with cisapride. The same caution as with KTZ or itraconazole needs to be applied in co-administering other drugs. Proton pump inhibitors and H2 blockers do not affect its absorption. Use fluconazole can be administered orally as well as IV in severe infections. 794. Section 12. Antimicrobial drugs. A single 150 mg oral dose can cure vaginal candidiasis with few relapses. Oral fluconazole, 100 mg per day for 2 weeks, is highly effective in oropharyngeal candidiasis, but is reserved for cases not responding to topical antifungals. Fluconazole, 100 mg per day, for 2 to 3 weeks is the first-line treatment for Candida esophagitis. Most tinea infections and cutaneous candidiasis can be treated with 150 mg weekly fluconazole for 4 weeks. For disseminated candidiasis, cryptococcal coccidioidal meningitis and other systemic fungal infections, the dose is 200 to 400 mg day for 4 to 12 weeks or longer. It is the preferred drug for fungal meningitis because of good CSF penetration. Long-term oral fluconazole maintenance therapy after initial treatment with IV. Fluconazole AMB is used in AIDS patients with fungal meningitis. An eye drop is useful in fungal keratitis. Fluconazole is ineffective in aspergillosis and mucormycosis and inferior to itraconazole for histoplasmosis, blastomycosis and sporo trichosis, as well as in tinea unguim. Siscan, Zocon, Forcan, Fluzen 50, 100, 150, 200 mg caps, 200 mg per 100 ml IV infusion. Siscan 0.3% eye drops. Itraconazole, this orally active triazole antifungal, has a broader spectrum of activity than KTZ or fluconazole, includes some molds like Aspergillus. Some fluconazole-resistant candida are susceptible. It is fungistatic, but effective in immunocompromised patients. Steroid hormone synthesis inhibition is absent in itraconazole, and serious hepatotoxicity is rare. Oral absorption of itraconazole is variable. It is enhanced by food and gastric acid. Itraconazole is highly protein-bound, has a large volume of distribution, 10 liters per kilogram, accumulates in vaginal mucosa, skin and nails, but penetration into CSF is poor. It is largely metabolized in liver by CYP3A4. An active metabolite is produced which is excreted in feces. T-half varies from 30 to 64 hours. Itraconazole is well tolerated in doses below 200 mg per day. Gastric intolerance is significant at 400 mg per day. Dizziness, pruritus, headache and hypokalemia are the other common side effects. Unsteadiness and impotence are infrequent. Plasma transaminase may rise transiently. However, antiandrogenic and other hormonal adverse effects are not seen. Impaired left ventricular function has been worsened in some patients. Drug interactions. Oral absorption of itraconazole is reduced by antacids, H2 blockers and proton pump inhibitors. Table 57.2 Properties of drugs used for systemic mycosis. Characteristic AMB Caspo5, FCKTZ Flu ITR Vori. Antifungal spectrum: broad, narrow, narrow, broad, 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 absorbed orally, no, no, yes, 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 administered IV, yes, 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 no, yes, 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 resistance, in vivo, no no yes, limited no no, nephrotoxicity yes, no 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 no, anemia yes, no, mild no 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 no, leukopenia no no yes, no 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 no, gastrointestinal upset yes, mild moderate mild, overall toxicity high low medium low low. AMB amphotericin B, 5-FC, flucytosine, KTZ, ketoconazole, fluconazole, ITR, itraconazole, caspofungin, voriconazole. 795. Chapter 57. Antifungal drugs. Rifampin, phenobarbital, phenytoin, and carbamazepine induce itraconazole metabolism and reduce its efficacy. On the other hand, clarithromycin and HIV protease inhibitors reduce the metabolism of itraconazole and raise its blood levels. Itraconazole inhibits CYP3A4. Drug interaction profile is similar to KTZ. Ventricular arrhythmias have occurred with terfenadine, astamizole, cisapride, and class 3 antiarrhythmics. Phenytoin, digoxin, sulfonylureas, statins, dihydropyridines, protease inhibitors, warfarin and cyclosporin levels are also increased. Uses itraconazole is the preferred azole antifungal for most systemic mycosis, see table 57.1, that are not associated with meningitis. It is superior to fluconazole for histoplasmosis, blastomycosis, sporotrichosis and is the drug of choice for the rare fungal infections, paracoccidioidomycosis and chromomycosis. It also affords some relief in aspergillosis. A dose of 200 mg OD/BD with meals is used for 3 months or more. Vaginal candidiasis, 200 mg OD oral for 3 days is as effective as intravaginal clotrimazole. Dermatophytosis, 100 to 200 mg OD for 7 to 15 days, more effective than griseofulvin, but less effective than fluconazole. Onychomycosis, 200 mg per day for 3 months. An intermittent pulse regimen of 200 mg BD for 1 week each month for 3 months is equally effective. Relapses have occurred after itraconazole therapy, though it remains in the nail for few months after completion of the course. Sporanox, Canditril, Candestat, Itaspor. Flucover 100 mg cap. Itaspor 100 mg cap, 200 mg per 20 ml. While important features of drugs used for systemic mycosis are compared in table 57.2. Voriconazole, it is a second-generation broad-spectrum triazole introduced lately for difficult-to-treat fungal infections like invasive aspergillosis, disseminated infections caused by fluconazole-resistant candida, fusarium infections, and febrile neutropenia not responding to antibacterial therapy. Serious cases are first treated IV, followed by oral voriconazole. It is completely absorbed orally, except when taken with a fatty meal, widely distributed into tissues and metabolized extensively by CYP to C19, CYP3A4, CYP to C9. Metabolites are excreted in urine. The T-half is 6 hours. It also inhibits CYP isoenzymes, and the drug interaction profile is similar to KTZ. Rashes, visual disturbances, QTC prolongation, and an acute reaction on IV injection are the significant adverse effects. Dose: 200 mg oral BD taken 1 hour before or 1 hour after meal. Begin IV infusion with 6 mg per kilogram 12 hourly infused over 2 hours twice followed by 3 to 4 mg kg 12 hourly. VFND 50, 200 mg tabs, 40 mg per milliliter oral suspension, 200 mg per vial inch. Fungiver 200 mg tab. Posaconazole, this recently introduced broad-spectrum triazole, has more potent antifungal activity and is the only azole which has shown efficacy in mucormycosis. It is indicated for salvage therapy of this difficult-to-treat fungal infection. Because of its high cost and limited experience, it is reserved for non-responsive cases of aspergillosis and invasive candidiasis. Favorable results have been reported in febrile neutropenia and as a prophylactic in immunosuppressed patients. It has also been used as alternative to itraconazole for chromomycosis. Side effects to posaconazole are common, but mostly limited to nausea, abdominal pain, loose motions, headache, dizziness and drowsiness. Anemia, neutropenia, cardiac arrhythmias, and visual disturbances are rare. Administered as an oral suspension, absorption of posaconazole is improved by low pH and fatty food. It is partly metabolized by CYP to C19 and glucuronidation, but excreted mostly unchanged in feces. The T-half is 24 hours. It can increase levels of drugs. Metabolized by CYP3A4. Dose 200 mg QID or 400 mg BD with meals. Noxafil 200 mg per 5 ml susp. Allelamine. Terbinafine, this orally and topically active drug against dermatophytes and candida, belongs to a new allelamine class of antifungals. In contrast to azoles, which are primarily fungistatic. 796. Section 12. Antimicrobial drugs. Terbinafine is fungicidal. It acts as a non-competitive inhibitor of squalene epoxidase, an early step enzyme in ergosterol biosynthesis by fungi. Accumulation of squalene within fungal cells appears to be responsible for the fungicidal action. The mammalian enzyme is inhibited only by 1000-fold higher concentration of terbinafine. Approximately 75% of oral terbinafine is absorbed, but only 5% or less from unbroken skin. First-pass metabolism reduces oral bioavailability to less than 50%. It is widely distributed in tissues, strongly plasma protein bound, and has high affinity for keratin. Therefore, it is concentrated in sebum, stratum corneum of skin, and into nail plates. Inactivation occurs by metabolism, and it is excreted mainly in urine, but about 20% in feces as well. Elimination T-half after single dose is 11 to 16 hours, but is prolonged to 10 days after repeated dosing. Oral terbinafine is usually well tolerated. Side effects are gastric upset, rashes, taste disturbance. Some cases of hepatic dysfunction, hematological disorder, and severe cutaneous reaction are reported. Enzyme inducers lower, and enzyme inhibitors raise its steady-state plasma levels. Terbinafine does not inhibit CYP450. Topical terbinafine can cause erythema, itching, dryness, irritation, urticaria, and rashes. Use terbinafine applied topically as 1% cream twice daily is indicated in localized tinea pedis cruris corporis and pityriasis versicolor. 2 to 4 weeks treatment is required according to the site, yielding high efficacy. Oral treatment with 250 mg OD is reserved for onychomycosis, tinea capitis, and widespread lesions. Duration of treatment varies from 3 to 6 months or more depending on the site. Efficacy in nail infection is tilde 80%, which is higher than grisofulvin and itraconazole. Terbinafine is less effective against cutaneous and mucosal candidiasis. 2 to 4 weeks oral therapy may be used as an alternative to fluconazole. Lamisil, Sebifin, the skill 250 mg tab, 1% topical cream. Exifine 125, 250 mg tabs, 1% cream, Turbiderm 1% cream. Other topical antifungals. All these drugs are used for dermatophytosis. 1. Tolnaftate. It is an effective drug for tinea cruris and tinea corporis, and most cases respond in 1 to 3 weeks. Because of poor penetrability, it is less effective in tinea pedis and other hyperkeratinized lesions. For the same reason, it is ineffective in tinea capitis, involving scalp, and tinea unguium, involving nails. Symptomatic relief occurs early, but if applications are discontinued before the fungus-bearing tissue is shed, relapses are common. Resistance does not occur. Salicylic acid can aid tolnaftate by keratolytic action. Tolnaftate causes little irritation, but is inferior in efficacy to imidazoles. It is not effective in candidiasis or other types of superficial mycosis. Tinaderm, Tinavate 1% lotion, Tolnaderm 1% cream. 2. Cyclopyroxolamine. It is a newer drug effective in tinea infections, pityriasis versicolor and dermal candidiasis. High cure rates are reported. It penetrates superficial layers and reaches hair roots, but systemic absorption is negligible. Local tolerance without irritation is good. Sensitization occurs occasionally. Formulated as nail lacquer, it has been used in onychomycosis. Vaginal candidiasis can be treated by 1% cyclopyrox vaginal cream. Batrafen 1% cream, 1% topical solution, 1% vaginal cream, Olamin 1% cream. 3. Undecylenic acid. It is fungistatic, used topically, generally in combination with its zinc salt. It is inferior to the drugs described above. Cure rates are low even after prolonged treatment. However, it is still used for tinea pedis, nappy rash and tinea cruris. Irritation and sensitization are infrequent. Tinifax, zinc undecinoate 8%, zinc naphthenate 8%, mesulfin 8%, methyl salicylate 2.5%, terpineol 2.5% oint. 4. Benzoic acid. It has antifungal and antibacterial property in slightly acidic medium. Fungistatic action is weaker than tolnaftate. 797. Chapter 57. Antifungal drugs. Eradication of the fungus needs prolonged application till infected keratin is totally shed. On hyperkeratotic lesions, it is used in combination with salicylic acid as Whitfield's ointment, benzoic acid 5%, salicylic acid 3%. The latter, by its keratolytic action, helps to remove the infected tissue and promotes the penetration of benzoic acid into the lesion. Irritation and burning sensation are experienced by many patients. Ring cutter ointment. 5. Butanafine. It is a benzylamine congener of terbinafine with the same mechanism of action. However, it is used only topically in dermatophytosis. Efficacy in tinea cruris corporis pedis is similar to that of topical terbinafine. Butop, Fintop 1% cream, apply locally once or twice daily. 6. Quiniodoclor by the oral route. It is used as a luminal amebicide, CH60. It also has weak antifungal and antibacterial activity. By external application, it has been used for dermatophytosis, mycosis barbae, seborrheic dermatitis, infected eczema, furunculosis and pityriasis versicolor. Quiniodoclor is also used in vaginal creams for monilial and trichomonas vaginitis. Viaform 3% cream, dermoquinol 4%, 8% cream. 7. Sodium thiosulfate. It is a weak fungistatic, active against Malassezia furfur. A 20% solution applied twice daily for 3 to 4 weeks is effective in pityriasis versicolor. However, normal pigmentation of the skin takes longer to return. It is not useful in other superficial mycosis. In Carpin lotion 20%. Problem-directed study. 57.1 A 50-year-old woman presents with complaints of constant pain in the retrosternal region for the past 2 weeks. The pain is markedly aggravated during swallowing. The condition has progressively worsened, and now even drinking water hurts. There is difficulty in swallowing as well. She informs that she is a diabetic and takes tab. Glibenclamide 5 mg twice a day for the past 2 years, but has not checked her blood glucose for the last few months. Endoscopy reveals diffuse streaks of creamy yellow mucosal plaques and a few erosions in the esophagus. Scrapings from the plaque are sent for microbiological examination. Fasting blood glucose is found to be 180 mg per dl. She is diagnosed as a case of esophageal candidiasis with poorly controlled diabetes mellitus. A. What drugs should be prescribed to treat her esophageal condition? What should be the duration of therapy? B. What are the aspects to be considered in view of the fact that the patient is a poorly controlled diabetic taking a sulfonylurea medication? See Appendix 1 for solution. Chapter 58 Antiviral Drugs. Viruses are the ultimate expression of parasitism. They not only take nutrition from the host cell but also direct its metabolic machinery to synthesize new virus particles. Viral chemotherapy, therefore, was considered impossible, as it would require interference with cellular metabolism in the host. However, in the past 50 years, virus-directed enzymes have been identified in the infected cell, and some viruses have few enzymes of their own which may have higher affinities for some antimetabolites or inhibitors than the regular cellular enzymes. In addition, drugs have been developed which target virus-specific steps like cell penetration, uncoating, reverse transcription, virus assembly or maturation, etc. Another stumbling block is that in majority of acute infections, viral replication is already at its peak when symptoms appear. To be effective, therefore, therapy has to be started in the incubation period, i.e. has to be prophylactic or preemptive. Classification. 1. Antiherpes virus idoxuridine, trifluridine, acyclovir, valacyclovir, famciclovir, ganciclovir, valganciclovir, cidofovir, foscarnet, fomiversin. 2. Anti-influenza virus amantadine, rimantadine, oseltamivir, janmivir. 3. Anti-hepatitis virus non-selective antiviral drugs primarily for hepatitis B, lamivudine, hadifovir dipivoxil, tenofovir primarily for hepatitis C, ribavirin, interferon alpha 4. Antiretrovirus A. Nucleoside reverse transcriptase inhibitors, NRTIs zidovudine, AZT. Didenosine, stavudine, lamivudine, abacavir, entricitabine, tenofovir, anti-RTI, B. Non-nucleoside reverse transcriptase inhibitors, NNRTIs nevirpine, efavirange, dilavardine, C. Protease inhibitors, ritonavir, adjanvir, indinavir, nelfinavir, saquinavir, umprenavir, lopinavir, D. Entry, fusion inhibitor, enfuvertide, E. CCR5 receptor inhibitor, maraviroc, F. Integrase inhibitor, raltegravir. Anti-herpes virus drugs. These are drugs active against the herpes group of DNA viruses which include herpes simplex virus 1, HSV 1, herpes simplex virus 2, HSV 2, varicella zoster virus VZV, Epstein-Barr virus, EBV, and cytomegalovirus, CMV. Idoxuridine, it is 5-iodo-2-deoxyuridine, IUDR, which acts as a thymidine analog. It was the first pyrimidine antimetabolite to be used as antiviral drug. It competes with thymidine, gets incorporated in DNA so that faulty DNA is formed which breaks down easily. It is effective only against DNA viruses, and clinical utility is limited to topical treatment of herpes simplex keratitis. Because of low virus selectivity, higher local toxicity, and rapid development of viral resistance, use of idoxuridine is restricted to superficial dendritic keratitis when rapid action is required. Idoxuridine eye drops act faster than acyclovir eye ointment, which is more effective when there is stromal involvement of the cornea. Ocular irritation occurs with idoxuridine eye drops. Dose 0.1% eye drops to be instilled hourly, then 2 hourly and 4 hourly. Apply 0.1% eye ointment at night. Idurine, Toxil 0.1% eye drops and eye oint. Trifluridine, it is a fluorinated nucleoside which acts in the same way as idoxuridine and inhibits HSV-1, HSV-2, CMV and related viruses. However, virus selectivity is low and DNA synthesis in host cells is also affected.